people, good morning, good afternoon, good evening, good night, depending on the time of the day or night that you're listening or watching this from. And also depending on the part of the world which you're watching us from. We are back again and we are so happy to be hosting our very first episode. Med Talks with S today is so excited to be hosting our very first episode as we promised. And our excitement is even greater because we are having our very first guest on studio. Our guest is one of the kind. One that you would love to watch and listen and gain so much insight, medical insight from him. Our guest is a medical doctor who has practiced in so many fields of medicine. He has practiced in cancer treatment centers. He has practiced in psychiatric departments. He has practiced in surgery departments. And currently, he is practicing as a medical officer in surgical department in one of the level 4 county hospitals in Kenya. So here we go. This is the time to introduce my guest. Good morning, Daktari.
Good morning to you, S.
I am so glad to have you in our show.
Thank you.
Thank you so much for accepting our invite. We have really been waiting for you and we can't wait to have you. I know that I have introduced you, but I would want to give this opportunity for you to even make more introductions about yourself. Karibu sana to the show.
Thank you. It's such a great honor and joy to be with S. And it's a great honor even more to be in this show, Med Talks with S. And being even the first interviewee is even makes it greater for me. My name is Mureithi Nyawira. I'm a medical doctor in general practice in this republic. As you mentioned, I've been working in different places, not so long, not so short, but I have been working in general practice. I've worked in a cancer center, I have worked in a psychiatric facility, and now I work in a surgical department, as you mentioned, in one of our sub-county hospitals in this country. But beyond that is that I'm also a family man. I'm a husband of one, Maureen Wamboi, and also a father to one lovely girl by the name of Nyawira.
Oh, wow. That is interesting to hear. And wherever they are, receive our greetings from Med Talks with S. So, Daktari, before we even get to our beginner topic today, I have an interesting question for you.
Yes.
I am just looking at you and thinking, what would you be doing if you were not practicing as a doctor?
Oh, really now? Well, I didn't see that coming. But if you let me, it might perhaps actually interest you. Because I highly suspect that if I was not wearing a stethoscope, I would be wearing a collar.
Oh, wow.
A priest's collar.
Wow.
Because in many ways, initially, I actually think after Form 4, I felt I wanted to go and join a seminary and become a Presbyterian minister. I really admired when they wore those robes that look like those of lawyers. But somehow I think the KCSE paper that I did was fairly easy, so I got virtually everything. So I decided to join medical school,
all right.
And that's why I find myself here.
So by default, by passing all your papers,
yes,
you're here as a medical
somehow
practitioner.
Yes.
And do you think, if you were taken back, you would still choose this path or you would still go for the robes?
Listen. Again and again, given an opportunity to choose, I will not think twice. Medicine is lovely.
Okay.
Well, of course, it has its bad days. It has tough moments as we will unfold, because I think in this episode we'll also be asking, are there days when you feel like you want to give up with this career called medical practice? And the answer obviously is yes. So there are times when it's hard and everything, but given a chance, I would choose, I don't know whether to say I would choose her again, but yes, I would go for medicine again.
Medicine all the way.
Yes, for sure.
Awesome. That's interesting to hear, and thank you for sharing that part of your life. And now back to our show. This is a new show, and I am glad to have you today. And the aim and the objective of this show is to address the gaps that we believe exist between you on that side as a medical practitioner and me on this side representing the general public. And I would want to ask you, do you think that such gaps exist, and do you think it is important to address these gaps?
There is, I think it's somebody who mentioned and quoted Mahatma Gandhi, the former Indian leader, and he used to say that if there was a great time to plant a tree, it's 20 years ago, but the next best time is today. And I would actually think that is what I would feel about Med Talks with S. This is a conversation that should have started long before.
Wow.
Because this is a conversation with purpose. And I think if I listen to the first episode well, I heard you said it's born out of purpose.
Sure.
And I would carry it along.
Absolutely.
And listening to you, I can tell, yes, there is a huge gap. Perhaps some of our viewers here did a book by Goge Wathiongo, The River Between.
I did.
Oh, excellent. Me too. That can, our viewers can maybe estimate when we were in school.
Yeah, sure.
But that's beside the point. But in that book, he speaks of two ridges that stood side by side. Was one Makoyo and another one?
Kameno.
Kameno.
Something like that.
And there was,
not Kameno.
oh, right, fell. Let it pass. But there was a river, River Honia,
Yes,
that was
River
passing
Honia.
between those two ridges.
Oh, good sharp memory.
And I would think that the gap that exists between the general public, because we were there, we were part of the general public before we joined medical school, and what is between the healthcare practitioner and the general public is even bigger than that rift between Makoyo and Kameno. And this conversation brings that gap closer. Perhaps you'd say we are building a bridge between those two ridges,
Exactly.
so that the general public, in one way or another, may hear what are the thoughts of the medical practitioners, what is their worldview, what do they think, how do they assume the patients should behave or listen or understand. But on the other side also, it's an opportunity for us medical practitioners to actually listen and hear. When we meet these people, what is behind their minds? What do they think is happening in the hospital? What is behind their coming to meet us? What are their expectations? Because also that is a big challenge in our society.
Sure.
Yes.
Thank you so much for actually reassuring us that we are on the right track.
Oh, yes.
And also stamping the fact that we said that this is a show that is born out of purpose. And also confirming that there truly exist gaps. And I think we are now in the levels, or we are now in seasons of life where we no longer, the general public no longer view the medical practitioners as a god or something.
Yes.
People are hungry for information. People want to know. And also finding medical practitioners who are ready to share stories, who are ready to talk about health, who are ready to talk to the public about the basic needs that we should actually know is quite important, and we do not take that for granted.
Actually, yes, if I would let you know, what you are talking about is what we oftentimes we call a paradigm shift. Mabadiliko ya jinsi mambo yanavyofanywa.
True.
And this paradigm shift is because previously we used to have what we used to call physician-centered healthcare. So physician-centered means that it is a healthcare provider who was at the center of it. As you've said, they were little gods. They know what is right. They don't question them. They say what they say. They write gibberish, and nobody cares. That is how often our grandparents and our parents view doctors to this day. They are small gods. But that is long gone for this generation. Because now what we have is patient-centered care. That at the center of care is not the doctor, but is a patient.
Sure.
Yes.
Sure.
So that something that perhaps we'll talk about it later. Long ago, if you thought about something called seeking a second opinion, perhaps you've heard people use that word. I'm seeking a second opinion.
True.
In our society is often seen as disrespect. Ati anataka kwenda kuuliza daktari mwingine mawazo yake, na already another practitioner has already given you their thoughts.
Yes.
If you think about it previously, it looked like amenikosea heshima, haniamini. But today we actually now encourage, like what you mentioned, I've been in cancer care, and we highly encourage it. I may have given you the plan, this is what we wish to happen, But we would also be glad if you'd talk to another healthcare practitioner and see whether we actually agree on this plan and whether what is easier for you, what is workable for you. So it's patient-centered care. And I think these conversations is part of that.
That is very true.
Yes.
I am glad to hear that part and that bit, that today a physician would be open to even tell a patient that you it's fine, you can seek for another opinion from another doctor, from another physician also. That is quite interesting, and I think from now on this side, people do that, but actually think, I would not want my doctor to know that I consulted elsewhere.
Yes.
So it's quite interesting to know that, and I think to our viewers that is an eye opener for us. So Daktari,
Yes.
in today's show we are not handling anything specific, any disease specific, but we want to just bring to the light all those things that we are speaking, so that we can be able to prepare our viewers and our listeners, and even create some base on where we are going to start. So I'm going to ask you some question.
Yes.
And before maybe we leave that part, I would have wanted you to give us some good examples of instances where you felt during your practice that you felt the gap really is there. Maybe probably where you felt this thing is quite basic, but then you realize that as you dealt with the patient, it is not basic to them. You can give us some interesting examples.
Well, that's quite well. Thank you. Yes, but that can be a bit hard because there are myriad, very many examples that come to mind. But perhaps I can take two, perhaps one in obstetric care, or what we call in pregnancy, and perhaps another one in general surgery. And I would think that one of the gaps that exist is, of course, the knowledge gap. The knowledge gap being that what the practitioner knows and what the patient or the person receiving care knows, there's a huge gap. And that one, of course, these might not be bridged over time because it takes practice and learning and so much. But take for an example, there are times when the practitioner, let me say the doctor for this sake, sees something and they think it's not so serious. They think it's something that will pass. They don't even think there needs to be a lot of intervention. But the other side, the person coming to receive care, or the patient, or the relatives, or the people close to them, think it's so serious, and the doctor should stop everything they are doing to attend to this person. But at the same, they don't feel like it's something that requires serious emergency. It's not something they think is life-threatening. But on the flip side, there are times when the patient thinks something is not so serious, and then they think they can actually let it go. As they say, atakunywa tangawizi ishe. But the healthcare practitioners feels like this is a person they can hold with their both hands and push sense into their heads. This is a very serious issue you are taking lightly. And I said in obstetrics or in pregnancy, there is something that you often call hypertension in pregnancy.
That is high blood pressure.
High blood pressure,
Okay,
yes.
okay.
But when it happens in pregnancy, and at times it happens, I'm sure we'll have that topic one of these days
Yeah,
with one of our
definitely.
providers, where they talk of hard words like preeclampsia, eclampsia, hypertension in pregnancy, gestational hypertension, those things. We will make them easy with time. But
Sure.
at times somebody doesn't feel anything. They don't have headaches. They don't feel even, they may be a bit tired, but they say it's because of pregnancy. But their BPs or their blood pressure is in the sky. It's in the roof. It's high. And then they may even have other things that now come together with it. They are just told, oh, we want to check a bit of your urine. No, I don't know. They start saying their proteins, and proteins for you is meat. And so they're wondering, why are they? Yes, I've been eating beans. So what is a big issue about having proteins in my urine? But for the healthcare practitioners, they know it is life-threatening. These are patients you may be speaking with today, as we are doing with you now, but in the next 5 minutes, we are looking for an ICU. So that's a gap that often happens, where we either think something is so serious when it's not, or at times downplay something which is extremely fatal. So maybe that's what I would come to mind.
Wow. And I think in many instances is when we think that something is not serious
Uh-huh.
with the general public.
Yes.
And sometimes we think some things are too serious, and when we come to the hospital we realize this doctor is not even taking this case seriously. Yeah. So Daktari, I want to ask, like, as a patient, what is the best way to communicate with my doctor or my medical personnel, and can that affect diagnosis? Yes, I just want to talk about that because I
Yes.
think it's important.
The communication aspect.
Yes.
Well, perhaps what we need to say, and it's important to say it early, modern healthcare practitioners are not magicians. And for them to come up with a diagnosis, for them to be able to know where you are healing from, you must give the accurate story. There is a joke, well, I don't know whether I should share it with the common mwananchi, but there is a common joke that patients lie all the time. That actually,
It's a
even
joke.
as, yes, it's a joke. Is it a joke or even a maxim?
No, that's a gap because
That's a gap.
I don't know about that joke.
Well, yes, that's why it's within us.
Yeah.
That they lie all the time. And even as you listen to them, you must always have your lenses that perhaps what they are telling me, maybe they are not lying, but perhaps they are not saying the whole truth. There is something they are holding, especially because it requires a lot of vulnerability and trust before you now can tell somebody the secrets and the hard things and the small minute and the smallest detail. Because for medicine, especially the modern way we practice, we start with something called history taking. Perhaps it's important to let people know that the first thing that happens after the introductions, after the it's history taking. That's the first, and it's actually the foundation. If you think of a beacon of the foundation of the house, is history taking. History taking means just sitting and giving the story. History, where you give us the whole story vulnerably. When did this whole problem start? How did it go? So every step, don't assume that maybe you had a cough but it didn't last for long, but then you had your knees paining, and for you may not think there is a connection between the throat infection you had and the paining knee. But at times that's a whole difference that makes us not say what you have is post streptococcal arthritis. Maybe it's because of that throat infection that you had, that your knees are paining. So at times you may assume it, but by giving that whole story and being vulnerable, and at times even giving those details you think maybe actually
Unnecessary.
stupid. Yes.
Yes.
But we need that whole story. So we start with history taking, and that's where communication matters. A listening ear. Of course, I think that's also important for us medics, because we need to learn to listen, and we are taught communication in school, where you have to have good listening skills, where people talk and you listen, and actually as they speak they are giving you the diagnosis. So that's a very important thing at the beginning of it. History taking, communication.
Okay, that's interesting to hear that patients actually lie. And as you're speaking, I was just here asking myself, like, why would I go to the hospital just to maybe withhold some information? But with your explanation of vulnerability, especially in history taking, I think it makes all the sense. And it is important for our listeners to know that bit, that giving the truth and telling the truth and being consistent in giving their history really matters.
Yes.
Because Daktari, I would ask, I think in hospitals you do tests, you send patients to the laboratory, you can do imaging or whatever it is, the CT scans.
Yes.
Why do you need to ask me too many questions when you can just diagnose?
I think even there is a joke where people say unauliza maswali mingi kwani wewe ni daktari.
Exactly.
And the question is mbona madaktari wako na maswali mingi?
Yeah.
And I have told you that actually it's very important to know that oftentimes when you are sent for those tests, they are not being sent so that we know exactly what's happening. At times is to differentiate between two possibilities. Let me make it easy for you. We've said that the first step is history taking. That's the most cardinal. It's actually the most important. I think there is one philosopher who said, listen to the patient. They are giving you the diagnosis. Just by listening, you are 90-something% aware of what is most likely happening with the person, because there are 1,000 tests that can be done. So which one do you decide? you cannot send a patient for
All of them.
all of them. So what tells you and what makes it possible for us to know this one requires this requires the another one is how we start the story.
Okay.
But after what we've called history taking, there is a next step where we actually call examination. Well, maybe most of us are used to examination kumaanisha mitihani, but even in hospital for us, after we take the history, the next thing that we go to is examination. And examination is just that, examining. Looking, it has like 4 steps. The first one is looking. Even as we speak,
Looking, you mean
yes,
eyes?
kuangalia
Okay,
na
okay.
kuona.
By
By just looking at the person, we actually use a technical word inspection, but it's actually looking. That as we look your eyes, we look to your hands, we look at your stomach, abdomen, you know, we can tell something is happening here. So that's the first step we do in that what we are calling examination. So we look. The other thing is we touch. They call it palpation. So touching means that at times we may just want to know, are the hands warm? You know, it may say a lot. There is a time when all you need to know is to greet a person and you can tell there might be a problem with their thyroid, you know, if the hands are so sweaty and such things. So being touched, or when the practitioner touches or the doctor touches, they are able to tell a lot of things.
Okay.
All right. So we've said that the first thing is kuangalia,
yeah.
yes, which we called inspection.
Inspection.
The other thing we said is palpation, which we said it's
Very
touching.
Okay.
Yes.
Yeah.
The other thing that is important for us, and perhaps there are people here who are in drums, those people who play drums, they may yes, they may say, they may tell you that they percuss. I don't know if you've heard of such a thing, a percussion note, that unaona ile kugonga drums, it's called percussion. And we do it often by producing voices. So you may hit a part, not well hit, but just kugonga kidogo kama venye hizo drums hugongwa, and there is a yes, and there is a voice that may come out and it tells you kuna maji huko ndani, ama kuna hewa mingi imekwamilia huko ndani, haifai. So just by hitting a bit and listening. All right. The last one, which oftentimes people think is everything, is when we use this, we call the stethoscope, which we do for hearing. So they use a hard word called auscultation.
Okay.
It's hiyo ni ngumu kidogo, but it's listening.
Okay.
So we look, we feel, by touching, we listen to the sound. It's actually now hearing by percussion, but lastly is that we listen. So ukiwekelea hii stethoscope kwa masikio, akiwekelea mahali, at times ni moyo anaweza sikia haupigi vile inafaa, ama ni kifua inatoa sauti haifai. So all that. So those are the steps that we go through before we actually now send somebody to the lab tu ni ya kutusaidia. I'm thinking maybe it's malaria, maybe it's something else. So how do we differentiate between these two possibilities? So that's when we send it. Now it helps us say, yes, and na nilikuwa ninasema. So that's what helps us to say, na nilikuwa nafikiria hivi.
You now draw a conclusion and make a diagnosis.
Sure.
Okay, wow, that's so interesting. I think we are getting more enlightened and we are having a clear understanding of why actually we have to be passed through all that we go through. Sometimes some things we think this is unnecessary, this is nothing is connecting to whatever they are asking me and actually filing. But thank you so much for that clarity. And as we almost come to the end of this show,
it's that short.
Was it? Okay, this is interesting because I would want you to I want to give you an opportunity to address one common myth that you have always had and has always given you some, that feeling which you feel like, no, I really need to address this. That is so common, so that our listeners can hear.
Well, there are 1,000 myths, and they varied by the circumstances where you find yourself. One of the common myths that we now hear ni watu wa kabuti nyeupe wako hapa tu watengeneze pesa.
Okay.
That they want to make money.
That myth?
Yes, it's important to talk about it early, because it's now common. Of course we know there is a lot of don't know whether to use hard words like consumerism, that now people have become so attracted to money and power and such things, so that even in healthcare, such behaviors start penetrating, or they start getting through and through. But I think it's a lie to think that people practice medicine to make a living out of people's lives, or to make money, or to take advantage of people. I know that we wake up in the morning, we struggle, we read, we study, and principally is to see that people are helped, that somebody who came with pain goes home relieved, somebody who came with doubts goes home aware of what's happening, somebody who came perhaps pregnant goes home holding a baby. That's always our wish, that there may be better society, that people would be better, and that there would be healing. We know there are exceptions, and we now hear of stories here and there, money and everything, but principally at the heart of it, it's a myth to think that we're just here for the money.
Wow. As you elaborate that myth, I'm just thinking of something that can come up and something we will hold a discussion one of these days with several guys like you, especially addressing the do we call them the riots or the demonstrations that sometimes keep coming, and the argument of people still rotates around the myth that, you see, these doctors are not just called, they are after money, and that is why they will go out there demonstrating. But I think it's a broad thing, because the public probably needs to understand something out of it, rather than tie it to the myth that you have just explained.
Yeah, sure.
Yes, but it's something we can talk about, and I promise you, my viewers, that we are going to have that discussion, and we will be encouraging as many questions as possible, so that we can be able to address this in a way that will be clearer to the public, and in a way that will also allow them to explain to us and to demystify that myth even in a greater extent. So Dr. We are so happy to have you today. We really appreciate your time, and as you sign out, would you maybe recommend one specific topic to this show that you think would be of great importance, so that we can look for an expert and have it here?
Thank you. Well, of course, you know, there are 1,001 topics that we can discuss.
Yes.
I am quite passionate about mental health myself, especially for the public. Although I now practice in the field of surgery, and that's what I do on a daily basis, but I still think that mental health remains one of the most misunderstood, one of the most that needs to be demystified. So mental health, I think, for me is so important for the community. When we talk about issues like depression, understanding them better, anxiety disorders, when you think about things like schizophrenia, you know, when you just say people are mad, but perhaps you need to know what's this exactly. There are now conditions people are understanding more, things like bipolar disorder, you know, all such things which oftentimes in the society they are viewed as, and there are now so many myths and misconceptions around mental health.
True.
So for me, I think that's one of the areas we need to discuss and talk about more. And we'll be very glad to have myself, and I'm sure many of my colleagues and seniors, and to just come and sit, and we have
a discussion around that.
Yes.
Wow, that is so amazing. I think we have had one of the best conversations with Dr. here, and I think that topic that you have talked about is a great concern to the nation and to the world, and we promise that definitely we will bring a panel of them, not even one, so that we can have that discussion broadly, and we can even reduce the stigma that comes with it. So I want to say thank you so much, our viewers, for keeping it here, for watching, for following to this very end. And if this show has been a blessing to you, and you feel that this is an information that should get out there to the community, please subscribe, share to as many people as possible, and let us meet again here for the next exciting episode, Med Talks with S, because health is human, health is life. Let's talk about it.